Hello friends, welcome to the next topic, that is Gouty Arthritis. The learning outcomes for this topic is that there is a definition and description of pathophysiological concept of the Gouty Arthritis. Then we will see the classification of drugs which are used in Gouty Arthritis, predict the pharmacotherapy for the Gouty Arthritis, and we will learn the various mechanisms and various of the various drugs which are used in the treatment of Gouty Arthritis. So very first we will see what is Gouty arthritis. It is the condition where there is a deposition of monosodium urate crystal, or simply it is called as a urate crystals in the joints, or monohydrate crystals in the joints. So monohydrate crystals are bring pathological reactions which are found in gouty arthritis, which is leading to the development of arthritis associated manifestations, etc. It is a group of disorder occur alone or in the combination with the given following disorders, that is hyperuricemia, monoocular inflammatory arthritis, deposition of urate crystals in the peripheral connective tissue in and around the synovial. So individually or in a group of this various symptoms come together to form this gouty arthritis. There is an interstitial deposition of urate crystal in the renal parenchyma also. As far as the types of concern, there is two types of gouty arthritis: primary and secondary arthritis. How they can be differentiated? It is like over here. There is an imbalance between the urinary elimination of uric acid and the formation of uric acid inside our body. About 1/3 of uric acid is it is coming from the dietary source, whereas a 2/3 uric acid is from the purine metabolites. So this there are two sources where from the uric acid will come inside the body: dietary as well as purine metabolites, and they will go by the urinary excretion. So concentration of uric acid inside our body will be the balance between the synthesis and elimination via kidney and the gut. So purine synthesis and degradations are regulated by xanthine oxidase. Xanthine oxidase is the enzyme which is responsible for synthesis and degradation of these purines, which is responsible for 2/3 source of the purine. It catalyzes the conversion of hypoxanthine to the xanthine and then to the uric acid. So purine synthesis by the xanthine oxidase, this is the main source for the uh, uh, occurrence of the uric acid. So hyperuricemia is the condition where the plasma uric acid level is more than 420 micromoles per 100 ml. If the uric acid concentration in the plasma is found more than 420 micromoles per 100 ml, then it is called as a hyperuricemic conditions. Okay. So increased production and decreased elimination of the uric acid, that is imbalance in between synthesis and elimination, which is leading to the or one of it or in combination both of it, which is leading to the gouty arthritis. There is increased uric acid into the body, which is leading into the hyperuricemia, gouty arthritis, deposition of urate crystal, and nephrolithiasis. Increased uric acid formations are these are the conditions where there is an increased urate formation. Primary iodopathy due to clinical conditions like hemolytic processes, lymphoproliferation disorders or myeloproliferative disorders, polycythemia, psoriasis, alcohol, obesity, or purine-rich diet. These are the conditions where due to that the urate formation will be excessive. It will be enhanced. Hypoxanthine phosphoribolize transferase deficiency. This is one of the conditions where the lead to the increased urate formation. As far as decreased urate formation is concerned, primary iodopathy elimination is concerned, decreased uric acid elimination is concerned, primary iodopathic type associated with clinical conditions like renal insufficiency, something where the kidney is not able to throw this uric acid outside the body. Polycystic renal diseases, diabetes insipidus, hypertension, lactic acid, diabetic acidosis, starvation, ketosis, lead intoxication, hyperthyroidism, hyperthyroidisms. These are the hyperparathyroidism. These are the conditions where uric acid elimination will be decreased. So elevated urate formation or decreased elimination. So these are the two conditions where it may lead to the gouty arthritis condition. Now the secondary gout, it is due to the drug ingestions and use of higher dose of salicylates, diuretics, alcohol, levodopa, ethambutol, pyrazinamides or nicotinic acid, cyclosporine. So these are nothing but the drug induced. So these are the drugs which are responsible for induction of a secondary gout. As far as pathophysiological conditions or pathophysiology of gouty arthritis is concerned, there is an interaction of urate crystal with the polymorphs, activation of the humoral cell mediated inflammatory reactions in that gouty arthritis. There is a release of bradykinase, killer killings and plasmin interaction which lead to the release of lysosomal enzyme and oxygen related free radicals, which is ultimately lead to the leukotrienes and prostaglandin synthesis. So phagocytosis of urate by the neutrophil lead to the release of chemotactic factors and leukotrienes. This lactate production in the synovial tissue and leukocyte associated inflammation, which favors the uric acid depositions. So no mono articular joints are affected mainly, and the other joints like ankle, midfoot, knee, small joints, wrist and elbows are also affected during the gouty arthritis or deposition of a urate crystal. So there is a rapid onset, make the patient difficult to move due to the affected joint. There is a severe pain, swelling and tenderness. A single joint will be severely paining and there is a tenderness, swelling, inability to move that joint, ready skin, ready and shiny skin around that joint. This is the pathological conditions. Then after that, the second part is a recurrent or chronic gout. After the acute attack, subsequent attack may lead to the disease progression or chronic may lead to the development of a chronic gout. It is take a shape of polyarteritis, continuous deposition of urate crystal, damage to the joint and chronic pain. This is leading to the more than one joint will start affecting. The main determinants are the serum uric acid level. Serum uric acid level is the main determinant of this condition. High level, early or more extensive joint damage may lead to this. The crystals appear as irregular firm nodules. They are irregular inside these crystals. They are firm nodulars deposited at exterior surface of the finger. They deposit at the exterior surface. Hands and forearms, elbow, they are most affected. Renal colics also occur during the gouty arthritis. As far as the drugs used in this concerns are concerned, there are two category of drug which is listed over here. The acute gout where the colchicine or non-steroidal anti-inflammatory agents are used, whereas for the chronic gout, the drug that inhibit the uric acid synthesis, that is xanthine oxidase inhibitors. Example is allopurinol is used. And the next category of drug, that is uricosuric agent like probenecid, which elevate the excretion of uric acid from the body. First drug, colchicine, used in a prophylaxis and also in the treatment of gouty arthritis. It is not an analgesic drug, have a narrow therapeutic index. Therefore, it is not a first line drug. Definitely, it will be the second line drug because the safety measure is more important. A narrow therapeutic index is the main constraint behind the use of it. It binds to tubulin and interfere with the function of mitotic spindle. These are the present inside your cells which are responsible for contraction and pain responsible for that. Depolarization and disappearance of fibrile microtubules in the granulocytes and other mitotic cells. So there will be disappearance of these tubulins, therefore by which the inhibit the migration of granulocytes to the inflamed area. So accumulation of this granulocyte into the inflamed area will be reduced. So ultimately the inflammation will be reduced. So reduced release of lactic acid and pro-inflammation enzymes. So pro-inflammagenic factors will be reduced by the use of colchicine. So inhibit the cell division by inhibiting the mitosis process. So other effect also listed over here. It inhibit the release of histamine from the granular mast cells, so the inflammation will be automatically reduced. Decreases secretion of insulin from the beta cells and body temperature will be reduced. Increased sensitivity to the central depression depresses the respiratory center, enhances the responsiveness to the sympathetic amines, constrict the blood vessel, and induces the hypertension. These are the other conditions or other effects of the colchicine on your body. As far as therapeutic use is concerned, colchicine is used in acute attack of a gout, to decrease the pain, swelling, and redness. Effectively, these are used in this condition. It is also used for the prophylactic in association with the chronic gout. As far as toxic effects are concerned, enterohepatic circulation of this drug is there. So therefore, there are much more GI side effect, nausea, vomiting. Chronic use may lead to the myopathy, bone marrow suppression, hematuria. These are the other side effect and toxic effect of this colchicine. Next category of a drug is the NSAID, and from that indomethacins and other NSAIDs are given. Salicylates are not preferred because they tends to rise the uric acid level in the normal therapeutic dose. In normal therapeutic dose, the salicylate rises the uric acid level, so therefore they are not given. So these indomethacins and other NSAID inhibit the prostaglandin synthesis and urate pathocytosis by the granulocytes. It is this indomethacin started as a dose of 50 milligram thrice a daily, and gradually then it will be reduced to 25 milligram thrice daily. Next is the next category of a drug. It is actually probenicid or uricosuric drugs. Actually, this category of drug prevent the reabsorption of uric acid. Whenever there is a excretion of uric acid from the kidney, some of this uric acid is getting reabsorbed by the tubulars, and this reabsorption process is inhibited by the uricosuric agent, that is a probenicid. So by this way, they increases the excretion and decreases the urate level into the blood. It is used in the patient with the chronic gout and who experiences the recurrent attack of the gouty arthritis. Mechanism of action is concerned, this uric acid, we know that it is freely filtered through glomerulus and reabsorbed through the proximal tubules. So probenicid block this reabsorption process, so they will be directly, the uric acid will be freely filtered through the glomerulus, and as there is a no reabsorption now, it will be secreted. So reabsorption will be blocked in the proximal tubule, and this will facilitate the urinary elimination of the uric acid. So thereby they decreases the serum level. So it reduces the miscibility of urate pool and retard the urate deposition inside the body. As far as pharmacokinetics of this probenicid is concerned, competitively absorbed after oral administration, peak plasma level reaches within 24 hours, half-life is 4 to 8 hours, and it is 90% bound to the plasma protein. Unbound fraction is cleared by the glomerular filtration. Next drug is the allopurinol. It is the metabolite of oxypurinol, inhibit the xanthine oxidase. Allopurinol is xanthine oxidase inhibitor. Hypoxanthine is a rate limiting step for the uric acid production. It is the structure, allopurinol is a structural analog of hypoxanthine. So in that way, it blocks the hypoxanthine and the uric acid production, it will be reduced by the allopurinol. It is an enzyme inhibitor type of drug. And by inhibiting the uric acid synthesis, they lower the serum uric acid level. By this way, they prevent the hyperuricemia and nephropathy. After oral administration, around 80% is orally administered, used for primary hyperuricemia, gout, secondary hyperuricemia, and also used in chronic gout, arthritis, gouty nephritis, urinal stones, impaired renal functions, etc. So these are the all the things which are related to the gouty arthritis. If you have any kind of a difficulty or doubts, here there are my contact details. Thank you very much.